Hiccups Maria Montanez Villacampa, MD Renee F. Del Carmen, MD Nita Hussain, MD Basics Description. Hiccups are caused by a repetitive sudden involuntary contraction of the inspiratory muscles, predominantly the diaphragm, and terminated by the abrupt closure of the glottis, which stops the inflow of air and produces a characteristic sound. Hiccups are classified based on their duration. Hiccup bouts last up to 48 hours. Persistent hiccups last greater than 48 hours but 1 month. Intractable hiccups last for greater than 1 month. System, S. Affected, nervous, pulmonary. Synonym, S. Hiccups. Sanguitis. Geriatric considerations can be a serious problem, particularly among the elderly. Pregnancy considerations. Fetal hiccups are rhythmic fetal movements, confirmed sonographically, that can be confused with contractions. Fetal hiccups are a sign of normal neurologic development. 1. Epidemiology. Predominant age, all ages, including fetus. Predominant sex, male-female. 4:1. Prevalence. Self-limited hiccups are extremely common, as are intra- and postoperative hiccups. Etiology and pathophysiology results from stimulation of greater than or equal to 1 limbs of the hiccup reflex arc, vagus and phrenic nerves, with a hiccup center located in the upper spinal cord and brain. 2. In men, 90% have an organic basis, whereas in women, a psychogenic cause is more common. Specific underlying causes include CNS disorders, vascular lesions, AV malformation, infectious causes, meningitis, encephalitis, structural lesions, intracranial/brainstem mass lesions, multiple sclerosis, hydrocephalus, syringomyelia, seizure disorder, diaphragmatic irritation, tumors, pericarditis, event ration, splenomegaly, hepatomegaly, peritonitis, irritation of the tympanic membrane, nerve irritation, pharyngitis, laryngitis, neck tumors, mediastinal and other thoracic lesions, pneumonia, aortic aneurysm, tuberculosis TB, myocardial infarction MI, lung cancer, rib exostosis. Esophageal lesions, reflux esophagitis, achalasia, candida esophagitis, carcinoma, obstruction, gastrointestinal disorders, gastritis, GERD, PUD, distension, cancer, hepatic lesions, hepatitis, hepatoma, pancreatic lesions, pancreatitis, pseudocysts, cancer, inflammatory bowel disease, cholelithiasis, cholecystitis, prostatic disorders, appendicitis, postoperative, particularly with abdominal procedures, metabolic causes, uremia, hyponatremia, gout, diabetes, drug-induced, dexamethasone, methylprednisolone, anabolic steroids, benzodiazepines, methyl-dopa, propofol, psychogenic causes, hysterical neurosis, grief, malingering, idiopathic risk factors, overeating, consuming carbonated beverages, excessive alcohol consumption, excitement or emotional stress, changes in ambient or gastrointestinal temperature. General prevention: identify and correct relevant underlying cause. S. Avoid gastric distension. Acupuncture shows promise compared to chronic drug therapy for controlling hiccups. 3. Diagnosis: hiccup attacks usually occur at brief intervals and last seconds or minutes. Persistent bouts lasting greater than 48 hours often imply an underlying physical or metabolic disorder. Intractable hiccups may occur continuously for months or years. 4. Hiccups usually have a frequency of 4 to 60 per minute. 4. Persistent and intractable hiccups warrant further evaluation. History: severity and duration of hiccup bouts, associated medical conditions that could be causative: gastrointestinal, cardiac, neurologic, or pulmonary disorders, recent surgery, especially genitourinary, behavioral health history, review of medications, alcohol and illicit drug use, physical exam, correlate exam with potential etiologies, e.g., RALS with pneumonia, organomegaly with splenic or hepatic disease. Examine the ear canal for foreign bodies. Head and neck masses and lymphadenopathy. Complete neurologic exam. Differential diagnosis: hiccups are rarely be confused with burping, eructation. Diagnostic tests and interpretation in hiccups lasting greater than 48 hours. If an underlying etiology is suspected, consider condition-specific testing as appropriate, e.g., CBC, electrolytes, BUN, creatinine, LFTs, amylase/lipase, metabolic panel, chest X-ray. Fluoroscopy can evaluate hemidiaphragm movement. Diagnostic procedures/other upper endoscopy, CT scan, or other imaging, of brain, thorax, abdomen, and pelvis to look for underlying causes. Head MRI with contrast. Lumbar puncture. The extent of the workup is often in proportion to the duration and severity of the hiccups. 2. Treatment. Outpatient, usually, inpatient, if elderly, debilitated, or intractable hiccups. Many hiccup treatments are purely anecdotal. General measures. Evaluate frequent bouts or persistent hiccups. Treat underlying cause when identified. 2,4. C. Dilate esophageal stricture or obstruction. Treat ulcers or reflux disease. Remove hair or foreign body from ear canal. Angostura bitters for alcohol-induced hiccups. Catheter stimulation of pharynx for operative and postoperative hiccups. Antifungal treatment for candida esophagitis. Correct electrolyte imbalance. Medical measures. Relieve gastric distension, gastric lavage, nasogastric aspiration, induced vomiting. Cautious counter-irritation of the vagus nerve, supraorbital pressure, carotid sinus massage, digital rectal massage, respiratory center stimulants, breathing 5% CO2, behavioral health modification, hypnosis, meditation, paced respirations, phrenic nerve block or electrical stimulation, or pacing, of the dominant hemidiaphragm. Acupuncture. Miscellaneous, cardioversion, medication. First-line physical maneuvers, breath holding, Valsalva maneuver, breathing into a bag, fright, ice water gargles. Others, swallowing granulated sugar, hard bread or peanut butter, biting on a lemon, pulling knees to chest or leaning forward to compress chest. Drug therapy. If physical maneuvers have failed or treatment is directed toward a specific cause of hiccups. Pharmacologic therapy. 5. B. Chlorpromazine, FDA approved for hiccups. 25 to 50 mg PO/4 TID. Metoclopramide, 5 to 10 mg PO QID. Baclofen, 5 to 10 mg PO TID. 2,4,6. B. Haloperidol, 2 to 5 mg PO/IM followed by 1 to 2 mg PO TID. Phenytoin, 200 to 300 mg PO HS. Nifedipine, 10 to 20 mg PO daily to TID. Amitriptyline, 10 mg PO TID. Viscous lidocaine 2%, 5 ml PO daily to TID. Gabapentin, Neurontin 300 mg PO HS, may increase up to 1,800 mg/day PO in divided doses. 4. B. 1,200 mg/day PO for 3 days and then 400 mg/day PO for 3 days in patients undergoing stroke rehabilitation or in the palliative care setting where chlorpromazine adverse effects are undesirable. 4. B. Combination of lansoprazole 15 mg PO daily, clonazepam 0.5 mg PO bid, and dimenhydrinate 25 mg PO bid. 5. B. Contraindications. Refer to manufacturer's literature. Chlorpromazine is not recommended in elderly patient with dementia. Baclofen is not recommended in patients with stroke or other cerebral lesions or in severe renal impairment. Avoid abrupt withdrawal of baclofen. Other possible drug therapies. 2,5,6. C. Amantadine, carbidopa, and levodopa in Parkinson disease. Steroid replacement in Addison disease. Antifungal agent in Candida esophagitis. Ondansetron in carcinomatosis with vomiting. Nifopam, a non-opioid analgesic with anti-shivering properties related to antihistamines and anti-Parkinsonian drugs, is available outside the United States in both 4 and oral formulations. Olanzapine 10 mg QHS. Pregabalin 375 mg/day. Issues for referral for acupuncture or phrenic nerve crush, block, or electrostimulation. cardioversion surgery/other procedures, phrenic nerve crush or transaction or electrostimulation of the dominant diaphragmatic leaflet, resection of rib exostosis. Complementary and alternative medicine acupuncture is increasingly used to manage persistent or intractable hiccups, especially in cancer patients. 3,4. A. Home remedies. 2. C. Swallowing a spoonful of sugar, sucking on hard candy, or swallowing peanut butter, holding breath and increasing pressure on diaphragm. Valsalva maneuver. Tongue traction, lifting the uvula with a cold spoon, inducing fright, smelling salts, rebreathing into a paper, not plastic, bag, sipping ice water, rubbing a wet cotton-tipped applicator between hard and soft palate for 1 minute. Admission, inpatient, and nursing considerations. Most patients can be managed as outpatients. Those with severe intractable hiccups may require rehydration, pain control, 4 medications, or surgery. Ongoing care. Follow-up recommendations: patient monitoring until hiccups cease. Diet: avoid gastric distension from overeating, carbonated beverages, and aerophagia. Patient education. See general measures. Prognosis: hiccups often cease during sleep. Most acute benign hiccup bouts resolve spontaneously or with home remedies. Intractable hiccups may last for years or decades. Hiccups have persisted despite bilateral phrenic nerve transection. Complications: inability to eat, weight loss, exhaustion, debility, insomnia, cardiac arrhythmias, wound dehiscence, death. Rare,